scheduling things. Number one is I still have a student that has an institutional to make up an exam, so I can't pass it back yet. A lot of you have come into my office like today to see them, so you're more than welcome to do that. I just can't send them out because I don't want to have to rewrite the exam. So I'll be in my office on Thursdays. If you want to do that, 12 to 1, or next Monday. And if you look at the schedule, we're really about halfway through the content, right about now. Okay? So right about now is pretty much halfway through content class. So you're just giving you a gut check of where things are. We're doing pretty good. We're on schedule. This thing sounds really loud. Okay. Is that better? Still loud? I'm trying to judge because when I get excited, so I gotta lower the time. Okay. About halfway through. There's 2 pre-quizzes that I maybe learned announced about, and then there's 2 post-quizzes this week, and we kind of talked about that last week. So 2 post-quizzes due by 11:59 p.m. on Friday. All right. We might have one more opportunity this semester for bonus. I've got some questions about the bonus. So the way this works is when we invite people from outside the university to come in to give a talk, it's nice if we have an audience for them to talk to. And if it's relevant to the stuff that we're talking about, then I think it makes sense to encourage you all to attend. So that's why I made the decision sort of off the cuff to have some bonus opportunities. It's not a lot of points. It's 1 point for coming. I haven't entered it yet. We'll probably have one more this semester, I'm guessing. Okay? Just to give you a heads up. All right. Any other administrative questions before we get started? Okay. So we're on nervous system disorders today. And we're going to talk a little bit of review, just to kind of dust off the neurons in your CNS. But before we do that, how about this? Why did the snake go to the baby toy store? Why did the snake go to the baby toy store? What was that? Yep, he wanted to get a new rattle. Nicely done. Okay, why did the detective stay in bed? Why did the detective stay in bed? He wanted to stay undercover. Okay. All right, last one. I kind of like this one. Okay. What did the eye say to the other? What did the eye say to the other? Just between you and me, something smells. Get it? That's Special Senses, Unit 5 and 201, if you don't remember. So you have to go back to your textbook to get that joke. Okay, so those are not too funny, but that's okay. Funnier than anything else you're going to see all day here. All right, so from a review standpoint, I want to kick us off with some slides about background. I also want to provide you with, on the YouTube site, I think there's 3 total. There's 3 videos, and I need to explain them a little bit. 3 videos on the YouTube site that are ancillary. That means I'm not going to ask questions about them on the exam. I'm not going to test you on it, but a lot of students want more information. Okay, so there's one video that's probably titled Clive. Okay, and Clive was an individual that had an infection. It was a herpes simplex infection of the brain. And it specifically isolated and sought out the hippocampus and basically destroyed the hippocampus. And so now in this patient, Clive, he has no short-term memory. And so he lives his life on about a 2-minute moment-to-moment consciousness. Now, old memories that have a strong emotional tie, like his wife, he remembers. I think her name's Deborah. And so you'll see, it's actually kind of cute, but you're going to see it's cute and it's also sad all at the same time. And you'll see this interaction between Clive and Deborah. And when she walks in the room, it's like he's seeing her for the very first time. And that's really what he says. Okay, they're British, so they talk a little funny, but if you follow it, watch it a couple of times, you kind of catch the words. Okay? We should put subtitles in there, like English subtitles. That was a joke. Another bad joke, sorry. So that's one video. The second video that's on there is an interesting one. This one is a patient who had the corpus callosum severed surgically, on purpose, not because of an accident. And the reason is this patient was having very, very bad seizures. And so to prevent the seizure from going from a localized area all the way to like a grand mal seizure, all the way through the entire brain, they would cut the corpus callosum to prevent it from going from one hemisphere to the other. And the hemispheric specialization is interesting to watch because we have a dominant side. Right? We all use both sides of the brain, but we have a dominant side. And so you'll see interesting things as the interviewer is interviewing this patient and asking him to do certain tasks. And in one sequence, he's supposed to put these cards in order. And so with one hand, he's putting it in order and he's watching it. The other hand is starting to change what he's doing. And it's almost like he does have two brains, just like we do, but they're not communicating with each other. Okay? And then the third one is an interview of two twins. Okay, two gentlemen that are twin brothers. They grew up together, and one suffered early Alzheimer's, not early, but suffered Alzheimer's, and the second one didn't have Alzheimer's. And so you're kind of getting this interaction between these two twin brothers because Alzheimer's, there's a very loose association genetically. Okay, we suspect that there's some genetic link, but we cannot prove that yet. So right now it's just we think so, we hypothesize, but we don't have good evidence. And so these twin studies of two elderly men that are genetically identical is sort of example. And these are old videos, really old videos. In fact, the video of the patient with the corpus callosum that was severed was on VHS tape. Okay, you'll have to Google that if you don't know what I'm talking about. Okay, so VHS tape, and so it's pretty crummy resolution. And so you kind of have to fight through that. But it was like videotaped in like the 1980s, and then to preserve it, we put it onto a digital medium. Okay, so that's on the YouTube site, and I used to bring in a guest lecturer, Dr. Miller, and he would talk about a whole segment on the central nervous system and central nervous system disorders. Okay, and so that guest lecture is also on the YouTube site of when he used to come in. He's a retired medical school professor. And he's not necessarily as able to come in and give lectures. Okay, so I was able to capture his lectures on video, and you can watch that. So there's a lot of ancillary material. Again, it's sort of for those that are interested. This is a huge section, and one lecture, and most of the sections in this class are this way, but this one I think is really exaggerated. One lecture, a 2-hour lecture on nervous system disorders is just, it's almost embarrassing to think that we're going to try to cover it even in a general sense. But that's what we have. That's the time that we have allotted to us. Okay? So there's some extra stuff on YouTube. If you want to come in and ask questions about it, if you've got curiosity, that's great. And hopefully that will whet your curiosity if you're kind of thinking about other stuff that you would like to learn about. Okay, so before we actually get into the content that's testable material, I want to spend a little energy, because for many of you, 201 was a while ago. Okay? Because you had to have 201, 202, and 205 before you could even enroll in this class. So it's probably at least a year ago, if not longer, I'm guessing. If you were pretty diligent, maybe it was only a year ago, but I'm guessing it was about a year and a half, maybe 18 months to 24 months ago, before you even looked at stuff like this. So I want to back up, and you might have to dust off an old A&P text. If you want my lectures from A&P on the central nervous system, they're actually still on the YouTube site. You just back out of that shell, and you go to anatomy, physiology, and you can scroll down, and you can watch these videos for central nervous system. Okay? But the stuff that's really important to describe are the cell types that exist in the central nervous system as well as the peripheral nervous system. And these cell types, in addition to neurons, which are the electrical conducting cell that we utilize to send information, we also have these support cells known as glial cells. So we have two main cells. We have neurons and we have glial cells. And in the central nervous system, the types of glial cells that we have, there are four. We have oligodendrocytes, which function to produce myelin. Remember, myelin is that wrapping around the axon that increases action potential speeds. We have astrocytes, and astrocytes are the principal cell responsible for repair. They're also responsible for transportation of nutrient and waste products. The astrocytes are the picture in the upper left. And you can see that it's in close proximity to the blood vessel as it kind of exchanges, helps to facilitate exchange of nutrition, not just glucose, but also oxygen, and then removal of waste products, metabolic waste products like CO2. The oligodendrocytes are the upper right. Then thirdly, we have the lower left, or the microglia. And the microglia act a lot like phagocytic cells. So they're sort of the small phagocyte in the central nervous system. And you're going to see them show up when you have an infarct or you have a hemorrhage. When you have damage to the neural tissue in the central nervous system, you'll see these microglial cells. They almost act like macrophages, but they're small. That's why we call them microglia. And then last, but definitely not least, in the lower right are our ependymal cells. And these ependymal cells line the ventricular network, and they help to give rise to the epithelium that surrounds the choroid plexus. And that actually is what generates your cerebrospinal fluid. Now in the periphery, so these are central nervous system pictures. This is the periphery. In the periphery we only have two. We have satellite cells and we have Schwann cells. Who can remember and tell us what the satellite cells are responsible for? And which cell do they most mimic? What's that? The satellite cells? Close. They're very similar to the oligodendrocyte. Okay, so their role, the satellite cell, I'm sorry, no, you're right. Astrocytes is the satellite cell. The oligodendrocyte is the Schwann cell. Sorry about that. My apologies. So the satellite cell is most similar to this astrocyte, where they're going to be transporting or facilitating the transport of nutrition. They're also going to form some structural support, where they kind of hold those neurons in place. And then the Schwann cell is the one that I was thinking of, is most like the oligodendrocyte. So it's responsible for producing the myelination. And we'll get to a disease where we kind of highlight Schwann cells and oligodendrocytes. And this is a autoimmune disorder that we've already talked about in the last lecture series, where we talked about multiple sclerosis. And now myelination is actually destroyed in a type 4 hypersensitivity. So we'll get there in a minute. So I want to remind you of the synapse, because there's a lot happening at the synapse. Right? This is a picture of the presynaptic side, and you've got a lot going on within this cell. This is the synapse itself, and then the postsynaptic terminal. And this is a blow-up of this little rectangular box right here, where you can kind of appreciate the presynaptic neuron and then the postsynaptic neuron as we propagate information down the path. Within the central nervous system and the peripheral nervous system, we actually have this decision tree, or this categorical tree, that we've studied. We studied this. This is the exact same slide that came out of my 201 lecture. And so in the central nervous system, we remind ourselves that the brain and the spinal cord make up the central nervous system. And in the periphery, we have two main categories, sensory and motor, of which both of them are divided into visceral as well as somatic. Visceral kind of being focused on the thoracic and abdominal cavities, and then somatic just referring to body, or basically everything else in the periphery. And then we further subdivide sympathetic versus parasympathetic. And just real quickly, the sympathetic tree is responsible for what types of activities? Fight or flight. We always say that, but let's just make sure we understand what that means. That's absolutely true. But what is fight or flight referring to? What are some physiologic things that will change? What happens to heart rate in this sympiomimetic situation? Heart rate goes up. Respirations go up. Okay? You're getting ready to flee, or you're getting ready to stay and fight. And the parasympathetic division, responsible for what? Rest and digest. So again, just to kind of clarify that terminology, rest and digest is referring to shunting blood really away from exercising muscle and moving it towards the gut, like post-meal, so that you can actually absorb nutrition and focus on digestion. Okay, focusing away from the periphery and now looking at the brain, central nervous system. Do you remember colorations or pictures? If you took my 201 class, and probably many other 201 classes, you probably have to at least be familiar, if not memorize, the different regions of the brain. And at least the way that I would characterize it in my 201 class is, the reason that this is important or valuable, that's a better word, this is valuable to understand this map of the brain, is if you have a lesion, or if you have trauma, or if you have damage to a certain component, you can anticipate what the clinical ramification is going to be. And the opposite is potentially true. If you see certain clinical symptoms, and you know what areas of the brain are responsible for certain behaviors, without even having any imaging, you can probably determine approximately where the damage is. Okay? So that's relevant for this class, because this is pathology, general pathology. So I'm going to point out too, but I want to encourage you, this is all the background, I want to encourage you to refresh your memory of those areas of the brain, because they are relevant. Okay? Another way of saying that is they are testable. They're testable in the context of, if you have a lesion in this region, what would you anticipate would be the result? Or the patient presents with the following, where do you think the stroke is? Make sense? Okay, I'm going to give you a very close to home example today. Okay? But let's talk about the left hemisphere, and let's talk about this regional specialization real quickly, is towards the posterior aspect of the central nervous system, the brain. We actually have centers that are really responsible for sensory. So a lot of information comes in on the dorsal root horns, moves up the spinal cord, goes into the posterior aspect of the brain, into the sensory areas, and then as information moves forward into the frontal cortex, you start making decisions about motor activity. Make sense? And if you remember that slice of the spinal cord that kind of looked like a butterfly, the dorsal root horns that came in the posterior is where that sensory information came in, and the ventral root horns is where the motor information went out in a reflex arc. And the brain is organized in a very similar map. And so, for example, we've got two centers that are influencers of speech. And Wernicke's area 22, this is sensory information. So it's information about understanding speech. And then Broca's area is in the motor side, and this is centers 44 and 45, and Broca's area is responsible for the formation of speech. So if you have a patient with a stroke in the Wernicke area, they may be able to form words just fine, but maybe they put them in the wrong order because they're just running at the mouth and the understanding of formulating the words isn't there. Or they might have difficulty understanding what you're saying, but if you wrote it down, they'd be able to actually understand. Okay? In contrast, if you have a patient with a hemorrhage or a stroke or a lesion in the Broca's area, they may understand you just fine, but they may actually, when they go to answer you, they might have a stutter, or they might have difficulty forming certain words or picking which words to use. So that would be a difference, a contrast, for example, between Wernicke's area and then Broca's. Make sense? Okay. The meninges and the ventricles. So with the meninges and the ventricles, what I want to remind us in this case is that there's this covering. There's this covering across the entire central nervous system. It's not just the brain, it actually extends all the way down through the spinal cord. In that covering, there's 3 layers. Remember these 3 layers? And the superficial most layer is referred to as what? What was the superficial most layer? It's right here on the screen. What's the one that's closest to the skull? Are you guys just shy, or you're waiting for me to tell you? What's that? Well, the periosteum is not one of the meningeal layers. What about this layer right here? The dura, okay? And then beneath the dura would be what? What's that? The arachnoid, and then beneath the arachnoid would be what? The pia. And then there was a space. You guys remember the space? What was that space referred to as? Well, there's a subdural space, but what's the space that houses the central cerebrospinal fluid? That subarachnoid space, right? All right, maybe we need to review this one a little bit. Okay, so that's why we're doing this. So we flow cerebrospinal fluid all day long. So we produce about 500 milliliters a day. That's half a liter. But we absorb the same amount. And it's circulating through because that helps the brain and the spinal cord to buffer metabolites. So we have vascular perfusion that happens within the organ, and then the whole organ itself is sitting in a basin, essentially, full of fluid. So it's floating. So we'll talk about different problems today of drainage of that cerebrospinal fluid. That's why it's important to remember where it was. Okay? All right. And then the central nervous system extends all the way down through the spinal cord. And as we move further down the spinal cord, so there's 3 axes in the central nervous system, right? We've got back to front, and the back was sensory, and the front is motor. Then we have right to left, specialization, and then we actually have what we call top down, okay? Or cranial to caudal, caudal meaning tail, and cranial meaning head. And as you move down, you get to lower level functions. All the way to the point of, at the spinal cord, these are where the reflexes happen. Reflexes don't even, the sensory information comes in the posterior aspect, and it immediately comes out the motor, and it makes you have a reflex. And then by the time it gets to the brain, you've already moved your hand away from the hot stove. So that's a reflex. That's a very primitive neural pathway. Now, when you're studying, or your personality, or trying to solve complicated clinical questions, or math problems, or composing music, these are complicated functions that happen up here. They don't happen down in the spinal cord. So as we move through the spinal cord, we see, if you remind yourself, we see these different autonomic functions that take place. So for example, at the level of the pons, right, we've got autonomic things like equilibrium, eye movements, respiration, posture, swallowing. These are things that you usually don't have to think about. And as we continue to work our way down, here's the cerebellum. This is the structure that's basically posterior to the pons. We see a lot of mass associated with the cerebellum. It's organized very much like the cerebrum. It's actually referred to as the little brain because it looks so much like the cerebrum. And it's responsible for a lot of different functionalities that we really take for granted, like muscle coordination. Right, back onto this slide. Muscle coordination. Some of our understanding or conceptualization of the passage of time lies here within the cerebellum. And we move continuously down, we get to our medulla oblongata. So the medulla oblongata controls reflex centers like sneezing, gagging, swallowing, vomiting, salivation, movements of the tongue and the head. We have cardiac centers that adjust heart rate, as well as the forcefulness of the beat of the heart. And just an interesting side note, right? Many, many years ago, a preferred method of capital punishment was hanging individuals. And so the way that this was performed was to fracture the spinal cord right at the level of the medulla oblongata so you would actually stop the heart. And now we've moved on to other more sophisticated methods of capital punishment. Okay? But still, with sniper fire, if they're trying to take out a target quickly, right, and as humanely as possible, this is the area that they're trained to actually shoot, right at the bottom of the skull. Okay. The autonomic nervous system, we're wrapping this little segment up. The autonomic nervous system is composed of two very sophisticated trees. Again, and I'm going to encourage you, if a lot of this is not necessarily review, or it's a little bit of review that you don't have a lot of the blanks filled in, I want you to do a couple of things. I want you to either go to my YouTube site and watch the Central Nervous System lectures from 201. Maybe email one of the 201 professors this semester and see if you can sit in on their class. Or dust off your old textbook and review some of these gaps. Okay? It'll make it a lot more tangible if you can recalibrate yourself with the different locations in the central nervous system. Okay? And then, of course, ending on parasympathetic versus sympathetic split, this is something that transcends out of the central nervous system and goes out into the periphery and has activity on basically every organ in the body. Every organ in the body. And you can pick one as an example. The parasympathetic, go look up the parasympathetic vagus nerve. Okay? And see how many, if you don't remember, how many different targets the vagus nerve hits as it innervates. And that just gives you evidence that as things leave the central nervous system, they have direct impact over a tremendous number of organs in the periphery. Okay? All right, so that's our little 15, 20-minute recap or overview of some material that's probably 12 to 18 months or maybe older from being in your memory. But it's somewhere there in the hippocampus. Somewhere. Okay? So you have to figure out a way to recall it. And usually, a good method is if you can have a strong emotional tie to the material. Good or bad emotions. Okay? The other one is a smell. But that's a little bit more awkward if everyone comes up here and starts sniffing me, okay? But here's a proof of this. So you think back to your childhood and you come up with a fond memory, oftentimes you can think of the smell that reminds you of it. Okay, like if it's grandma, maybe it's apple pie. Okay, or maybe it's like Thanksgiving. Or maybe like Thanksgiving wasn't so great in your house, so that actually doesn't bring back good memories. So it works both ways. Okay? All right, let's talk about some of these acute brain disorders. Now that we have this background that we're essentially all up to speed on, we'll just call it that. So I want to remind us of the organizational structure of the meninges, because we're going to talk right now about the difference. See, we're launching right into pathology. But here's the most important thing to understand, because I always get these questions from students. I'm taking 201 or I'm taking 202. Can I just take your 320 class? I was like, you know what? We're not doing anybody any favors if you don't have the prereqs. Like, we don't just make up that crap to give you a hard time. Like, we actually make that formula so that you can actually understand what the heck we're talking about. Okay? So, in this example, I'm comparing and contrasting cerebral edema with hydrocephalus. And in 201, you talk about hydrocephalus, but you usually don't spend any time talking about cerebral edema because you talk about ventricular CSF circulation. But you don't get into pathologies that would cause cerebral edema. So what's the difference? Well, here's two pictures that look very different, don't you think? I'm going to show you a third one that's not on your slides. It's like fresh off the Keller family press. I'm going to share that here in a second. So this one right here, this is the left ventricle and this is the right ventricle. That's the left ventricle and that's the right ventricle. This isn't normal, but this has a different issue. The ventricles are relatively fine. But do you see how swollen those chambers are? So this is a picture of hydrocephalus. So hydrocephalus translates to water on the brain. And hydrocephalus occurs when you have either an overproduction of cerebrospinal fluid, like instead of half a liter, maybe you're making 1,000 or 1,500, or you don't drain it. It doesn't go back into the arachnoid villus at the same rate that it's being produced, so it kind of builds up. Or some combination of the two. Most oftentimes it's not draining. And if it doesn't drain, you get this accumulation and this pressure, and then you start blowing out the ventricles. But that puts a lot of pressure on the brain. Okay? So this is actually an impaired flow or absorption problem. And you get this accumulation in the ventricular system. Whereas in cerebral edema, this is saying accumulation in the brain parenchyma. So the brain parenchyma is the functional brain tissue. It's not the ventricular system. And this functional brain tissue, what do you observe that's unusual about this slice through the brain? That is a coronal slice, so it's a slice down like this. Does that make sense? Like right through the top, down this way. And now you're looking at it from the front. And so this is the patient's left, this is the patient's right. What do you observe? I already told you what's different here. What do you observe about the bottom line?
Left side is bigger.
What's that?
Left side is bigger.
The left side is bigger than the right side. I agree. We call this a midline shift. Can you appreciate how this doesn't go straight down? Okay, you can't even really see the midline here because it's blown out, but this is a midline shift. You can kind of see how this one right here looks a little crooked. Looks like it's kind of going like that. So this tells us that there's a lot of cerebral edema, and if you compare the features in the right side here to the features in the left side, you can kind of appreciate where that swelling is. Make sense? So there's two main causes that can take place that we typically see with cerebral edema. We've got either a cytotoxic or a vasogenic. Cytotoxic is there's an increase in fluid in the brain, usually due to hypoxia or some ischemic injury that could be due to a toxin. It evolves over minutes to hours, and it could be reversible if you get rid of the toxin or if you get rid of the hypoxic event. The second cause or usual circumstance is what we call vasogenic. And this is usually because the blood-brain barrier is disrupted and fluid is leaking into the brain tissue. You often see this associated with inflammatory injuries in the brain or as a result of a brain tumor. Okay? And so this little recall is when we have ischemia or hypoxia, what happens to the cells? They die. And if you have death of cells, you're getting what? What's that? Loss of function. We have necrotic tissue. What kind of necrosis would we be dealing with in the brain? What's that? It's like wah, 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 wah. That's all I heard. Sorry. Liquefactive. Thank you. Liquefactive. So this helps us, I think, bridge the gap of earlier information that we've learned about liquefactive necrosis as a result of hypoxia. And that would be a cytotoxic type of result. Vasogenic is most common in tumors. And so here's a picture that's not in your slides. This is a picture of a patient. And this is a top-down view. This is the patient's right side, and this is the patient's left side. You can appreciate one of the ventricular systems in this mid-slice right here. And what are some things that you're noticing about this head scan?
More white matter.
What's that?
More white matter.
More white matter? That's actually not white matter. That's actually fluid.
More fluid.
There's more fluid on the right side, but that's a very astute observation. It's a pretty obvious picture. This is my mom's brain in July. Do you guys notice the midline shift? This is where when you know just enough to be dangerous, it makes it very nerve-wracking as a family member, right? So this was mom's brain. She had a tumor in the brain. It metastasized from the lung. And she was having vision issues, memory loss. She wasn't acting like herself. And this is all as a result of vasogenic caused cerebral edema. Right? I took all of the name off for HIPAA reasons, but my mom wouldn't care. So the tumor itself is probably a little difficult to appreciate, but it's right here. Can you guys see this right here? So it's a little bit lighter white, a little bit more of a grayish white right there. But all of this fluid is a result of that tumor that's being grown in the right hemisphere. And if this is the front of the brain, right, correct, and this is the back of the brain, what centers are up here that are completely pressured out, meaning they're being squished? What centers are in the frontal cortex? What's that? Decision making? What's that? Sorry. Motor function? Yeah. So she started walking like this. And she, this is when we started understanding if things weren't right. Something was wrong. We needed to get something looked at. Personality. Her personality started changing. As soon as we had the tumor removed, she went back to mom. She almost instantaneously. That, in addition to steroidal therapy, shrunk down that fluid and actually gave her a lot of relief. Now we're wrestling with the lung cancer. Okay, but the brain's clear. Okay, so a new picture that you don't have, it'll be on the video. We have the explanation, but this is a classic example of vasogenic cause of cerebral edema. Okay? All right. So cerebral edema. This is not mom's brain. Okay? So this is a case. Obviously, this is an autopsy. But what I want you to understand and appreciate is, do you see how flat the surfaces of the gyri or the ridges that are raised? So these surfaces are flattened because they're pushing up against the skull cap. So if you back up to mom's picture, right, from July, we obviously didn't open up the skull cap and look at it. Can you imagine and appreciate what you think her brain tissue was looking like and how much pain? She was complaining of chronic headaches. That was another big one. And this is a different patient, obviously, but you can kind of appreciate how swollen the whole tissue is. So very different than cerebral hydrocephaly. This is cerebral edema. Okay, questions on the two? Yeah.
Well, the swelling goes down, can they like
Yeah, so the question is, the swelling goes down, do they actually become unflattened? And I would say yes, they will. They'll actually kind of remodel and take the shape that they were supposed to have. Okay, so cerebral edema, absolutely an issue that you're going to run into with your patients, okay, or a family member. But I also want to characterize how hydrocephalus is still a clinical concern that you may actually have experience with in the future. So this is a patient, Runa Begum, at 18 months of age, and this is like a real picture. That is not a morphed picture. That's not an iPhone app. That is actually her real head, okay? And she is a little girl in India. This is how extensive, again, not cerebral edema, this is hydrocephaly. This is how extensive the disease became. So it's more common among infants, and actually it does strike older patients. But older patients, those soft spots in the cranial cap are not cartilage. And so the skull can't expand like it does in infants. And this pressure of hydrocephaly enabled the skull to expand to the circumference. So she's at a head size of 94 centimeters, which is 3 times the size of a normal baby's head at that age. Okay? We see this much more in the third world countries because the healthcare is not as prevalent as it is here. But it is somewhat common. A very poor family, like her dad was a brick kiln manufacturer and made $3 a day, so that's $15 a week, and was saving up to try to have the surgery, but at that rate, they weren't going to be able to do it. So some college students were on a trip to India, to this village, and this village let them know about Runa. And the village is in India, it's called Tripura, Tripura. And these were international college students that decided to do a crowdfunding website and tried to raise $1,600 to cover the shunt surgery. So the surgery is to place a shunt from the subarachnoid space into the arachnoid villus to drain the fluid back into the venous circulation. $1,600. Okay? Your course fees are probably more than that each semester. And in 2 months, they raised double that amount, and by 6 months into the process, they had raised more than $60,000 to cover the expenses. There was a lot of follow-up surgery that was necessary, some of it being cosmetic, just to try to get her head size down. So that money was well spent. This is her after surgery. Okay, that's the hospital security right there. You see that? Isn't that interesting how they have like machine guns? So very different than our mall cops or our hospital security. This is her about a year after the surgery, and you can see that her head size has come down significantly. And the whole thing is you have to catch this early in these young kids so that you don't run the risk of causing permanent damage. Okay? So not as common in this country, and in elderly patients when the shunting is not appropriate, you don't have as much time. In our geriatric population, because the cranium is actually fixed in size by the time you are very young in age. So really about the age of 3, your head size is pretty fixed. Okay? And it'll grow circumferentially a little bit on its own, but you're not going to get these massive growth. So in the elderly, there's not a lot of space. Okay, so like in mom, it wasn't hydrocephaly, but when fluid started building up, it really puts a lot of pressure on the brain tissue because the cranial cap won't flex. Question?
I got 2 questions actually.
Okay.
So was she in like a substantial amount of pain with it? Looks incredibly painful.
Yeah, but I mean, she was mostly sleeping all day long. You know, and you know, babies cry, and if you ask them what's wrong, they just cry, you know, and then they poo, and you know, then they cry again. And so, you know, it's you know, if you guys want to be pediatricians, hats off to you, because that to me is as difficult, I think, as veterinary medicine, because you can't ask the patient to tell you what's wrong, right? Like I asked my dog, like, why he did that, and he just looks at me, like, then I give him a treat because he's so cute. You know, so it's like pediatric medicine and vets, I mean, that's really tough work. Trying to figure out when someone can't communicate what's going on. So yeah, I mean, she was very listless, she wasn't eating very well, she would cry, she was obviously in pain, and the family had their own like local therapeutics for pain management. You know, they don't go to Walgreens and get, you know, baby Tylenol, you know, for example. But yeah, I mean, things were going quite well, and I've been keeping track of Runa just because I was rather fascinated when I came across the story. You had a second question?
Yeah, and also the surgery, was it so cheap because it was in India, or is it just generally a cheap procedure in the United States?
No, I think it was, I mean, third world countries, medicine isn't as expensive as it is in the States. But, you know, the comorbidities and mortality rates in the United States are the least in any nation. So, you know, it doesn't, I gotta be careful on how I answer this question. It doesn't bother me to pay for quality health care, because I think that's a really important thing to pay for.
Yeah.
But, you know, in other countries, sometimes you only have what you have available. You don't have that option. Okay, so let's talk about back to my mom's example, okay, with cerebral edema. Could happen with hydrocephalus, but it's more common with cerebral edema, which is the scenario of the two that you're going to be more likely to come across. Unless you're going to do like Doctors Without Borders, or you know, you're going to go international. It's not to say that we don't have hydrocephalus issues in this country, but usually we shunt in pretty quickly. And the babies' heads don't get like that in the United States. But cerebral edema is a very likely scenario. And brain herniation is a problem. It's something we were very worried about with my mom. And brain herniation is a result that happens due to a severe increase in intracranial pressure. Now, you're going to get an increase in intracranial pressure with either hydrocephalus or cerebral edema. It's just you're going to run into cerebral edema much more commonly in this country. So the right image is a pattern of where the injuries take place, the common locations. The most common is the subfalcine. This subfalcine hernia is where the brain tissue itself bulges out, and that's what a hernia is, due to pressure. And as it bulges out, it's compromised for becoming necrotic tissue because it's under pressure. And then you might lose the function of that tissue if you don't correct it, if you don't relieve the pressure. So subfalcine, uncinate, an uncinate hernia down here, kind of at the level of the brainstem, and then further down, you've got tonsillar down the brainstem, and then what affects the brainstem in its entirety is something that's got its own terminology known as a Durrett hemorrhage. So a Durrett hemorrhage is a type of brain herniation, even though it's got the word hemorrhage associated with it. Now, we'll get to hemorrhage later. Hemorrhage is basically active bleeding. And so you may or may not have active bleeding in any of these hernias. But Durrett, this was named after a physician, Henry Durrett, and it's called the Durrett hemorrhage because it's affecting a vast majority of the brainstem altogether. A little confusing because this one says hemorrhage and the other ones don't. You could get hemorrhage with the others, but you may or may not get hemorrhage with any of them, and they're all still types of hernias. So if we look at down the list as we start migrating, other types of diseases that can attack or can influence the central nervous system, the next one that we need to talk about is cerebrovascular disease. Now that's a fancy word for stroke. Okay, so we're gonna So my mother this summer was misdiagnosed as having, not possibly having a stroke because of her behavior. Or maybe some mini strokes, or what we'll call later here, we'll describe them as transient ischemic attacks. But that's not what it was. In fact, it was a tumor, like what I showed you. And we'll talk a little bit more about cancer next week, because that's what's up next week. And so I'll use kind of Mom's story as kind of the platform to talk about some of the different types of cancers that can affect the brain. But we're not there yet. So we thought it was this, but it wasn't. This is an abnormality in the vasculature. And the abnormality in this vasculature can result in really 3 different processes. You could either have what we refer to as a thrombotic occlusion. A thrombotic occlusion is where a piece of thrombus floats downstream and gets stuck in a blood vessel and blocks it off. And then you prevent blood flow to that distal tissue. Or you could have an embolic occlusion, where you get a clot that forms somewhere else. It breaks off and moves in the bloodstream to a place further away, much further away, and then it gets lodged and stuck there. Usually a thrombotic occlusion is really close by or right there in that location. An embolic occlusion is it came from somewhere else. So you've heard about patients or people talking about when they travel, they're worried about DVTs, deep vein thrombosis. So if you sit on an airplane for like 15 hours, you don't move, your blood is kind of, not flowing really well, so they tell you to do these exercises. And what they're trying to explain to you or encourage you to do is to move your blood around so that you don't get thrombus formation. Because if you get clotting of the blood and it dislodges, it could actually end up as a pulmonary embolism, or it may unfortunately end up into the heart and then get shot within the brain. And that could cause a stroke, and that would be an embolic occlusion. Or a third category is vessel rupture. The vessel itself is so diseased, and we're going to talk about that disease at the very end of the semester. But for now, you just have to appreciate that the lining and the medial wall of the blood vessel that you learned about in 202, that becomes diseased with atherosclerotic lesions. That's a combination of fatty streaks that lead to calcified plaques, and the integrity of the wall of the blood vessel is compromised. And if it's compromised and it's under pressure, it could actually burst. Okay? So that would be a hemorrhage, and then you're going to have direct tissue damage and secondary ischemic injury. With the top two, because there's no blood flow, you get tissue ischemia, because there's no blood going to those distal portions of the brain. So when we compare this to global cerebral ischemia, because this previous slide that we looked at, this is in one location. This one is actually global. This is all throughout the brain. It's not because one blood vessel is actually targeted or affected. It's because you actually have a situation where you've probably reduced blood flow to the entire brain itself. Well, when is this going to happen? When you get a systolic pressure lower than 50 millimeters of mercury for any sustained period of time. That's pretty low. And so when would that happen? That's usually in a traumatic situation. Okay, so your scenarios where you're going to have a systolic pressure of 50 millimeters of mercury is when somebody's, exsanguinating blood volume. Usually a motor vehicle accident or a motorcycle accident. Years ago, about 10 years ago, I used to work at Gore, and the product line that I supported was a thoracic endograft. And this is an endograft that would reline the aorta right around the turn. And a large component of our population that we would treat was for traumatic transection. There's a ligament that kind of goes right across the aorta, right at that curve, and that ligament kind of holds it in place. And in motorcycle accidents, and the most common patient that we would go treat were 18 to 22-year-old males, okay? And the sudden injury of, going from 60 or 70 or 80 miles an hour to nothing the body does this, and the aorta swings forward, and it severs it right at that ligament. And you know, you're pumping out about, you know, you're going to exsanguinate your blood volume of 6 liters in about 60 seconds. And so we would, you know, if it's a complete transection. And so that's when this would happen. But there would be a lot of other cases of just regular motor vehicle accidents where you might see hemorrhage taking place. Okay? You might actually see hemorrhage taking place, unfortunately, in childbirth. Okay? If the mother is hemorrhaging and losing large blood volume and they can't get blood fast enough, that systolic pressure is going to drop. So you've got our clinical outcomes. Mild is going to be, you know, maybe some confusion. Severe is going to be widespread death of neurons, and then the patient might end up in a coma or in a long-term vegetative state. So we've got 2 different situations here. We've got our cerebrovascular disease, or a stroke, which is a localized lesion, and then we have global ischemia, which is all over the brain. So if we tease down further into focal ischemia, we usually see this result as a lack of blood flow that causes an infarction event. And so this is that focused area, not the less than 50 millimeters of mercury of systolic pressure. And this infarction is usually going to target a very specific area, okay, that is going to be a liquefactive necrosis as the tissue dies off. And the root cause is because there wasn't enough blood flow. It could be either due to thrombosis or embolism that we talked about previously. Remember that thrombosis is maybe the blood vessel is, the lumen of the blood vessel is narrowed because of disease over time. So if this is the blood vessel, and this is a normal lumen, in this diseased blood vessel, you may have a lumen that narrows down like this because you have all of this disease that's actually taken up this medial wall. And so the blood flow itself has a smaller diameter that it flows between, and this eventually can clot off. So if this clots off, that's thrombosis. If some clot piece breaks off from somewhere else and moves downstream and plugs this lumen, so this is the lumen, this is the lumen, then that would be an embolic event. Now, the good news for many of us is that we have this circle of Willis, right? The carotids go up, they bifurcate, and as they come up to the brain, there's actually sort of this redundancy, and that's what this picture is trying to show in the upper right. It's trying to remind you of the cerebral vascular circle of Willis. It gives you some collateral flow, some backup flow. But unfortunately, deep structures of the brain do not benefit from that collateral flow because it's a little bit more superficial. So these are structures like the basal nuclei, the thalamus, and the deep white matter are much more susceptible to strokes than superficial locations because they don't have the benefit of this circle of Willis. So it's not an all or nothing thing. What I mean by that is, and back to July when we were seeing some behavioral abnormalities in my mom, and the docs were talking about maybe there was a mini stroke, or what we call a TIA. So what is that? Transient ischemic attack is what it stands for. We use the terminology mini stroke because it's not a full-blown stroke. What it is we've got disease. Again, mom didn't have this. I already told you she had a tumor. But there is a loss of blood flow because here's a normal vessel. This is the common carotid bifurcating right here. This is the bifurcation, diving deep into the internal and then moving a little bit more towards the superficial surface, and that's the external carotid artery. And so you can see the black lumen is opaque dye that's filling the space. And on a diseased vessel, this narrows. So there's less black you can see on the internal carotid artery, right, just past the bifurcation. That's definitely narrow. It looks a lot like this drawing here on the right. And in the narrowing of that event, you get some temporary loss of blood flow to the brain tissue. Why is it temporary? Well, we can actually open that back up. But if you don't open back up, these transient ischemic attacks, they may in fact progress to a stroke. In fact, they're very predictive for a future stroke. And so a patient that has a transient ischemic attack is much more likely to develop a stroke later on. In fact, a third of all patients that present with a TIA left untreated will have a stroke within the next year. So what does a stroke look like? And then I'm going to talk to you about how we treat it. And then we're going to take a little bit of a break. Well, this is a cerebral infarction. So I thought you said stroke. Well, a transient ischemic attack, a mini stroke, left untreated can move on to a stroke. A stroke just means you have an infarction event where you have necrotic tissue dying. That's going to be liquefactive type of necrosis. You get all this inflammation coming in, right? Because it's a wound healing event. And this is the histology of what would happen or what it would look like if it went on to a stroke. Okay? So what we see here, the low magnification on the upper left, it almost looks like someone put a glass of water on a photograph and now there's this ring. You see that little ring, this demarcation line? And this area inside is where the stroke took place, and this is all sort of normal tissue on the periphery. If we start to zoom in, we zoom in on one of these little structures, these little features. That's what you're seeing right here, a little zoom in there on that's panel C. So in C, we've got edges of the lesion that we've characterized. All of these little purple dots are all inflammatory neutrophils that have moved in early on. And then panel D, which is actually down here, the lower left, this is about 10 days later. So what cell type would you expect at 10 days post-infarction? Macrophages, okay? So if we follow our cascade of events, we see neutrophils moving in, right here. All these little purple dots are kind of collecting. 10 days later post-infarction, we start seeing prevalence of macrophages. These are activated macrophages, kind of in our sort of peak of inflammation, our second wave of inflammatory cells that move in. And then over in panel E, this is about 2 to 4 weeks later, the macrophages are starting to subside. You see how much bigger these cell types are than these? So these are larger macrophages than the neutrophils. And in addition, here they're starting to dissipate. They're starting to go away. And what is this structure right here that you see? Scar tissue. Right? We've referred to it in neural tissue as a gliosis. Right? A gliosis. And what cell types do you think are responsible for manufacturing that scar? So we have astrocytes and we have microglial cells. Both of them have a role in actually this scar formation. And this is as good as it gets in neural tissue. Same kind of thing happens in the heart. So the brain and the heart, the scar is very prevalent. And so if you move into cardiac medicine or if you move into neurovascular medicine, having scarring of that tissue is not a good thing. Because this means there's a loss of function. There's no neurons that regenerate. They don't come back. That means you can't use that tissue again. It's not just that, oh, it looks a little yucky because I have a scar on my arm. It's like mom or dad doesn't have memory anymore. Okay? Or that component of the heart tissue, the myocardium, doesn't work anymore. We'll talk about that at the very end of the semester, which is, we're halfway through, so it's not that far away. Okay, we're going to bookend the semester talking about inflammation. I promise to you that we'll have inflammation throughout the semester. Hopefully you believe me. Okay, so this inflammatory process that takes place is what gives rise to scar formation. Well, we call it a special fancy name, a gliosis in neural tissue. And that's what really the problem is. Now, I don't want to leave for the break on a bad note. So, let me tell you a little bit about the therapies that are available, and then we'll take a break. Okay, when we come back, we're going to kick it off a little bit with a case study that I have from a recent student that did an internship with the medical examiner. Okay, right here in Flagstaff. It's kind of some cool information that she gathered in her internship. So, we have two main ways that we treat neurovascular events. Number one is we use drugs, okay, pharmaceuticals. So the pharmaceuticals that we will use, I hate the word, so I'm not going to say it. I was going to say blood thinners, but I don't like the word blood thinner. We use drugs that inhibit the coagulation cascade. Okay, and in common language, we refer to those as blood thinners, but that's really a poor terminology. Okay. So inhibiting the coagulation cascade, we're going to use things like antiplatelet drug therapy. So over-the-counter aspirin. Right, aspirin was invented in the mid-1800s. It has so many different activities that the Germans didn't even know about. If we were trying to get it through the FDA today, it would never be approved. It has way too many side effects. And you can go buy it over the counter. It's like the miracle drug, in my opinion, aspirin. Okay? So patients that are on aspirin, in fact, it's very common for an elderly population to take a baby aspirin every day. What do you mean by a baby aspirin? It's just a small aspirin that has a low dose. That's all it is. Okay? So aspirin. Now, if you want other drugs that are prescription-based, you might use a drug like Plavix or Parasympathetic. And all of these are going to prevent the blood from clotting. So if you get a narrow area, it's less likely the blood's going to clot in that area if you actually can block the coagulation cascade. So that's one thing that we do. The second thing that we do is we now use endovascular therapies. We still do surgical cutdowns, but the numbers are dropping every year because people don't want to have a big old surgical incision in their neck to get to the carotids, or why go up and open up the brain to get to a neurovascular vessel? If you can cut in from a leg artery, or even from the arm, usually we'll prep the right arm because it's an easier shot up to the carotid. But sometimes they'll come in from either side of the femoral arteries, which is, the femoral arteries are right at the groin where as the thoracic aorta turns into the abdominal aorta, and right about your belly button, it branches into the iliacs. And then it makes it away, and it has to scoot around the pelvis. And as it scoots around the pelvis, it comes more superficial. So right here at the groin is where the femoral arteries are actually really close to the surface. In fact, you can palpate and feel your blood pressure here. But it's a little bit more awkward to take your pulse. Let's take our pulse together. Everyone's like got their hand here in their crotch. It's a little awkward. That was like totally on the camera. That's weird. So it's like a little bit more, culturally sensitive to do it like this or like this, right? So don't take the pulse of your neighbor any other method than here or here. It's a little bit more awkward. Okay, but you can access very nicely the carotid vasculature, and we insert up a catheter that has a stent crushed down on it. Okay? And then we'll use a balloon to inflate that stent, expand it. We deflate the balloon, and we pull the balloon out, and we leave the stent behind. We can put a graft, or we can cover the stent if we want to. Those are called stent grafts. We can actually coat this with a pharmaceutical that prevents blood from clotting or that prevents cells from proliferating. Right? Those are called drug-eluting stents. Okay, so the idea is, here's our carotid vessels of our internal and our external pair. This is the section right here on this patient. And you can kind of appreciate how this narrowing is kind of what I drew right here. And the idea is you want to open this back up. So you go from this radiograph to this radiograph post-therapy. And that's how we treat. And this is a very, very, very successful and a very common procedure today. And it's probably what you all will be experiencing, or some iteration of this. Now, these Drug-Eluting Stents, Endovascular Therapy. If I go back to when I was in college, okay, this is the post-Jurassic era, but still is a while ago. Endovascular therapy was happening, but it was brand new. I remember in grad school, there was a radiologist who was working in collaboration with my advisor. And she was like this, I was going to say cowboy, but cowgirl. She was like total renegade. All the radiologists thought she was just, a loose cannon because she was doing these in patients. This is in 1990, I'm going to date myself, 1996. Okay, so in 96, she was putting these in patients down at the U of A and doing clinical trials, and it was brand new to the space. And 96 seems like a forever ago, right? Some of you were born in 96, huh? Yeah. How many of you were born in 96? Oh, look at that. That's awesome. Okay. So the only thing that's not so cool about my job is I get older and you all stay the same age. It's really weird. But in 96, 20 years ago, just 20 years ago, this was brand new to the space. Okay? So in 20 years, when you guys are old people like me, imagine what we're going to be doing to the patients. But you're probably going to be doing something like this. We just don't cut anymore. We just don't cut and sew in neurovascular. Okay? There's a lot of great therapies. All right, let's take a break, and then we'll come back and start with a case study.